introduce our next speaker. She's a very special guest from India. Dr. Deepa Bankar is professor and head of department at Smith neonatal Municipal Medical College in Ahmedabad. She's member of KMC Foundation India and faculty of Advanced Neonatal Resuscitation Program and KMC training. Today she's going to talk us about COVID experience in Indian neonatal units. Please welcome Dr. Deepa Bankar.
Namaste. Greetings from India. I feel blessed and privileged to be here, and I thank the organizers of KMC Congress, especially Dr. Carmen Pelas, to invite me and give me this opportunity to share my COVID experience in Indian neonatal units. The flow of my talk will cover the pandemic and rapidly changing guidelines, studies and experiences from India, from our center, our patients' experience, and I would like to share a little bit about our study on traumas and victories of NICU. When the world was in grip of COVID-19, we all know that the new normal was born. And this new normal was born out of extreme fear, apprehension, uncertainty, and anxiety. And that got reflected into rapidly changing guidelines, because when you think in fear, it's never permanent. And we also had 3 versions of guidelines by the professional bodies. Unlike elective medical and surgical procedures, which can be deferred during the pandemic, the pregnancies and childbirth continue. And with this novel pathogen and no knowledge about the disease, no evidence-based answers about the potential outcome in neonates or compatibility of the breastfeeding, it was the transmission to the baby was a major fear and major concern. And this concern was also born out of fear. And that was also shown in our 3 versions of guidelines. That first was on 26 March, which suggested the prompt umbilical cord clamping and avoiding skin-to-skin care. And in 40 days, it was changed to delayed cord clamping and advising skin-to-skin care. The experience from India was published by National Neonatology Forum. They created a COVID-19 registry, and this registry was created in a short span, and data was contributed by 20 hospitals across the country with the objective to describe clinical outcomes and risk factor for transmission in neonates born to mothers with COVID. And subjects were neonates born to the mother with the COVID positive or neonates who were diagnosed to be tested COVID positive. This registry had included 1,713 neonates, and they noted perinatal transmission in 8%. The horizontal transmission was noted in 1.5% of intramural neonates. Neonates roomed in with mothers had higher transmission risk. There was no association found with the mode of delivery or type of feeding. Majority of neonates were asymptomatic, and amongst those who were symptomatic, the symptoms were related to prematurity and perinatal events. So this data from the large cohort concluded and suggested perinatal transmission of SARS-CoV-2 infection and increased morbidity in infected patients. There were more such experiences and studies from southern India, northern India, and central India, with a major focus on transmission of infection and outcome of the newborns, and none of them reported any adverse neonatal outcome. We also had, I will describe that later, and at a designated COVID hospital, we had 333 neonates born to 329 COVID positive mothers. And we found that symptomatic neonates, there were 33 COVID positive neonates and 300 neonates were COVID negative. 24% of the neonates in COVID positive group were symptomatic as compared to 12% in COVID negative. The most commonly observed symptom in COVID positive neonates was surprisingly neonatal hyperbilirubinemia, and the respiratory distress was most commonly observed in COVID negative group. We also have a 6-month follow-up. This is not a very accurate follow-up. It was with the telemedicine and telephonic call. But for this talk, I did collect some data on immunization, feeding, and development. And immunization has majorly suffered, so has exclusive breastfeeding, which is almost 64 to 78% in positive and negative neonates, and the illnesses were mainly respiratory. So by now, this large experience from India and all over the world, it's clear that vertical transmission is extremely rare. The transmission could be entirely preventable if we follow the strict infection prevention control guidelines. And luckily, more than 95% of the term-infected babies remain asymptomatic. And among symptomatics, symptoms are related to prematurity and complications. Here, I would like to share my experience from our center, that is Sardar Vallabhbhai Patel Institute of Medical Education and Research. It is a very newly built hospital. It started in 2018. It is a 1,500-bedded multi-speciality teaching hospital with 32 operation theaters, 139 ICUs, HDUs, and the unique facility of electronic medical record in digital with the digital real-time data, which is not so common in our country, with the largest oxygen capacity. With the lockdown in the country, all the health services were disrupted. Private hospitals were closed, and amongst the rising number of cases, even in my city, which has 8.5 million population, our hospital was designated as a COVID hospital, COVID-designated hospital, and it was instructed to offer services to all the patients free of charge. It worked on all standard operation guidelines, but the unique feature of our hospital was it was the first hospital to have an outreach program as home care for asymptomatic or mildly and moderately symptomatic patients. The team used to go to home and measure their vitals and give them treatment. So our hospital should not be very crowded with the admissions. Till date, our hospital has admitted 18,735 patients, 15,331 patients tested positive for COVID, 13,206 patients have recovered. Unfortunately, we lost 1,538 patients. This data covers also the numbers from 2022. When our hospital was designated as a COVID hospital, we started seeing overwhelming number of acutely ill and dying patients. There was frequent change of patients' arrangement, and at a time, we had almost 1,000 patients in our hospital. We had separate floor allocated for doctors and their families who became positive. Our NICU was located on 6th floor, but then it was used for adults because they needed more oxygen beds. And we were shifted to 4th floor, and then eventually to 2nd floor, and with separate areas for suspected and confirmed cases, but we were not provided with the separate NICU. There was no designated ward for pregnant mothers and neonates. Probably they could not arrange it because of so many numbers. I have seen like 15 ambulances lined up in our ER, and we used to go to the emergency and see that whether we provide oxygen in the ambulance and take patients inside on priority basis because we had no vacant beds. There was no facility to transport or store express breast milk. It was a very traumatic experience. I still get tears in my eyes. And regarding pregnant women and the COVID waves, the first wave, when it started, it was kind to pregnant women. None of the pregnant women required oxygen. They were fine. And we were also happy that fortunately, this virus is not affecting the pregnant women. But the second wave in April 2021, it killed many pregnant women. Many women required oxygen, and we lost many of them. I talked with my physicians and obstetrician friends, and they said that they found that the mother presented either with the severe presentation or there was sudden worsening of the condition. In the ICU, where there are 80-year, 70-year-old patients with the many comorbidities, they could shift them to the rooms, but they lost these pregnant mothers, and it was very traumatic to hear this. Our physicians were concerned that if the baby could be delivered early, mother could be saved. But the obstetricians were concerned about non-obstetric indications of the delivery, and they asked for certain parameters for the concern of on-table death and excessive bleeding. Amongst all this, our first baby was born on 20th April. And it made a headline. It was first in our state, first baby to come to our hospital, and it was 7th in the country. And this baby was a baby of my student. He was father was a pediatrician, and He was a past student of our institute. Mother was a microbiologist. This baby was 38-weeker, was conceived by in vitro fertilization, delivered by cesarean section, weighed 3,200 grams. All the private hospitals were closed, so they came to our hospital. Grandparents were also tested positive, and the mother held the baby in her arms on day 14. She denied keeping the baby with her, denied giving breastfeeding. She threw away all the colostrum because she was so scared of transmitting infection to the baby. And this made us it was a tearful experience, and it really moved us. And we realized that when life begins in COVID times, in spite of having all normalcy of outcomes, it starts with extreme fear, apprehension, and anxiety. And parents cannot share the moments of joy, take pictures, create memories. And we got a feeling like, is COVID stealing the colostrum? Is it questioning the age-old gold standard of care of neonatal practices? And it made us aware. Suddenly, it was eye-opening experience of some important concerns other than the transmission, for mother, for baby, and for the doctors. When we could feel the mother's pain because she was scared for herself. Her antenatal care was discontinued because of the lockdown. She was scared for her unborn baby. There were experiences that the mothers who were serious were not ready to move oxygen in EAT because they were worried that it will kill their baby if they are not maintaining oxygen. So they refused food for continuing oxygen in ICU cares. They were anxious about the delivery process. They did not see any familiar faces at the scene. They did not go to the doctor they were seeing till now. There was no companion to accompany her, or there was probably no willing companion because most of the family members also were infected. And it was very difficult for her to understand this differing guidelines. For a normal person, they think that this is a very dangerous virus and it is easy to get infected, and once you get infected, you die in a short time. And that scenario and that understanding in the general population, she was scared to embrace skin-to-skin contact or go near her baby and give the breastfeeding. And she had a lot of unanswered questions about her baby. But the baby, we knew that had two concerns, that I want my mom's touch and I want my mom's milk and I want to be with my mom. I'm 3.2 kg, why should I be in an ICU? And why should I have formula milk? The doctors, besides their concern for self-protection and frequent updates on guidelines, most challenging part was counseling mother and family and identifying healthy caretaker to support baby and mother. And this made us identify the problem. We formed a conceptual framework and designed a study to identify barriers to breastfeeding and kangaroo practice at multiple levels in COVID times. It was a prospective observational study with the Institutional Review Board approval, with the aims and objectives of identifying barriers to adoption of postnatal guidelines for mother, for family, for nurses, for doctors, for administrators, and not only finding barriers, but also to attempt to find solutions and enablers of this gold standard practices. We had 70 singleton neonates. We excluded critically ill mothers and critically ill neonates. All mothers were tested positive because it was a policy to test. All mothers coming to hospital for delivery should be tested irrespective of the symptoms, and 89% of these mothers were asymptomatic. 60% of the mothers had at least one family member infected, and 80% of these mothers, fortunately, were aware of KMC. 16% of the fathers were positive at the time of delivery, and 7% of the neonate in this population became tested positive for COVID, but they were not having any adverse outcome. Regarding barriers for mothers, the top 5 barriers were related to COVID and anxiety related to COVID. They were feared for infecting the neonate. They were not comfortable with the situation, and they had adjustment issues because they were fine, they were asymptomatic, but thus, because they were tested positive, they were shifted from non-COVID to COVID hospital. And they had difficulty in understanding these differing guidelines. Since many family members were positive, 77% of them had a concern of lack of support from the family, and the mothers, and they also had so at the time, we had that mother was in one hospital and the baby was in other hospital because the baby was tested negative, so she was kept in non-COVID and mother was kept in COVID hospital. For the family, the barriers were, the first barrier was fear of getting infection himself. Many relatives even denied coming to because when father was positive, we had hard time because you have to find the caretaker who does not have any comorbidity. Because we were also scared that if the grandfather or grandmother has diabetes and hypertension, should we bring her to the COVID positive ward and take care of the baby? There was fear of infecting the infant was also found in 94% of them. They had 44%. This was a very traumatic to know that 44%, and in the 44% of the cases, the elders took the decision of not breastfeeding. They instructed, and they were the decision makers that to say that, no, we don't want to breastfeed, and they were not given breastfeeding. And in 10% of the cases, there was no designated person for taking care. We were the caretakers for newborn because all the family members were infected, and there were nobody. Regarding barriers for nurses, we recorded responses from 30 nurses, and the top 3 barriers were resource related. They had issues with the hospital facility and challenge to store the express breast milk. They also had record keeping challenges. 40% of them were concerned about mother's ability to practice, because if she doesn't have any caretaker, she herself is in the pain. How can she give KMC and BF and change diapers and keep baby without any caretaker allowed? And the increased workload due to KMC and extra responsibility was also observed in 10% of them. When we recorded the physician's response regarding barriers to these practices, they found it was very difficult to approach patients admitted at various levels because all patients kept on coming, and we started finding more and more oxygen beds, and there was no designated wards where we keep the mothers or we keep certain patients, and all the doctors of different specialty were repurposed. So they also found it very difficult to convince non-pediatric colleagues to practice these guidelines. And lack of support from nurses also was perceived in 40% of the cases, and also the 10% were concerned about the infant safety. For administrators, the top 3 barriers were restricted visitor policy, concern for safety of this intervention, and they perceived that staff was not ready to take accountability and responsibility. And this all responses were influenced by concerns for media. Media was showing every day rising number of cases and mortality, and we also had overwhelming number of acutely ill and dying patients, and so the authority was more concerned about critically ill patients. And they also had lack of staff because almost 80% of our staff got infected with the COVID, and at a time they were not able to work. So after identifying barriers, we tried to find the solutions, and we insisted on our persistent insistence. When the number of patients slightly decreased, they provided us with the 2 designated wards for mothers on 6th floor. We could also bring change in the visitation policy. We held 2 training workshops and also celebrated, this is a proud moment that we celebrated Breastfeeding Week celebration with a poster competition. And we also gave mother a booklet on KMC so that she can read, and we could strengthen the counseling, and also always adherence to protocols. This was a nursing training timetable. It was for 2 days. We held such 2 workshops. It covered 9 important topics and trained nurses on most essential skills with a more emphasis on skills, and we skilled 80 nurses. These are the pictures of that training. Then this is our very motivated 3rd year. I have to thank her and mention her. She's Dr. Ishani Sharda. She's a 3rd year resident. She came with the idea of celebrating Breastfeeding Week with a poster competition. She designed the announcement of the poster, circulated in the group, and we were overwhelmed to see such an encouraging response from the nurses and doctors. And these are the impact of our training. Because we held the training in July and this was in August, and we could see the impact of our training and overwhelming response. These are the models made by our NICU nurses showing sad mother with the formula, and on this side the happy mother with the KMC, and also the posters with the meaningful messages. I like this caption by our pediatric resident. This caption says, "This pandemic, let's prioritize while we sanitize." And he designed a detailed poster mentioning extra care during COVID-19 and also how can we help these patients. And most of the posters depicted breastfeeding and COVID, KMC and COVID. And the booklet also helped us counsel the mother. We also stuck those posters in the postnatal ward, and then we started seeing more mothers. These are COVID-positive mothers wearing gloves, wearing cap, wearing mask, and giving skin-to-skin and breastfeeding to their babies. Also, we could see more mothers and the caretakers in the NICU, and this is a $1 million picture of a smiling baby saying that I'm loving it. And we could see such more meaningful moments together in our NICU with the more presence of father, grandmother, and our small newborns grew. And we also could see the many shining and smiling newborns in our NICU. So to conclude, understanding of specific barriers during COVID-19 times is very important for to form the practice and policies, staff motivation to practice or to offer support for these practices is very vital. And the first touch and the first feed is nature guided, it is God made, and it should always be, it is even more important in more difficult times like COVID. It offers more benefits beyond our imagination. And these are our shining and smiling babies in our NICU. Thank you. Gracias.
Thank you very much, Deepa.